Now, we all owe it actually to Röntgen because he was the first guy who introduced X-ray, and without X-ray we would not be doing interventional cardiology. As you can see here, he actually did a picture of the hand of his wife. We all wonder why he didn't try first on the hand of his mother-in-law, but it was the hand of his wife, and she survived it. Of course, our big hero of basically everybody here, but for me personally, is Andreas Grünzig. And David just said, it's kind of unjust that he died so young, as a dapper-looking, stunning. As a dapper-looking, stunning personality. And we can only surmise, he would be 85 this year. You can only, looking at his face, kind of surmise what he would be looking like if he had lived. Now, I say this particularly to the young colleagues, if you come up with a new idea, and hopefully you will, you have to be convinced about your idea, and you have to be willing to have this thing done, or to take whatever you recommend yourself or next of your kin. And Andreas Grünzig was like this, when he was 45 years old, he said, I want to see my coronary arteries, and if I have any problem, I want my procedure done on myself. And as you can see here, absolutely stress-free. That's at the end of his coronary angiogram. The guy doing it was not completely stress-free, as you can see here. It was Hal Whitworth, one of his fellows in Atlanta. And when you think that only a radial approach brought outpatient coronary angiography and PSCI about, that's not true. I mean, that's Andreas Grünzig after his coronary angiogram, a couple of hours later, leaving for his office. And of course, we have to talk about the hero on the other end of the catheter. David also alluded to him. Dolph Bachmann, the first patient, very young when he had the procedure, same age as Grünzig at the time. And you see here Grünzig looking on. That was the balloon, a fixed wire balloon, but you could still use this balloon for a simple lesion nowadays. It would still be working. And he actually will turn 85 tomorrow. It's his birthday, and he's in good shape. I kept contact since this first initial intervention, where I played a minor role. I think I played a major role, because the caption here says, how I saved the first PCI patient's life. Imagine if I had walked away, he wouldn't have survived. I held his groin. It was at the time a 9 French catheter, by the way, to do angioplasty. Now, let me just dwell a moment on this first patient, because this is a historical patient, world's first PCI patient, still alive, closing in on 50 years of his initial procedure. Now, this here you see the lesion as it was, the initial lesion. This is 10 years after balloon angioplasty, a pristine result. Couldn't look any better. Exactly on the day, was it 10 years that this control angiogram was done. Now, for 23 years, I kept doing stress tests on him, and he was fine. He had stopped all medications because he has a firm belief that taking medications for a prolonged period of time, they lose their effect. So no medications for 23 years. And after 23 years, he called me and said, now I have the same symptoms again that I had in 77. Why don't you take a look at it? So I took a look at it, and I saw that there was what I thought a mild lesion here, which was about in the territory of the initial lesion. So I didn't want to spoil the story. In every other patient, I would have put in a balloon and just dilated, no questions asked. But on this particular site, I thought I cannot spoil this story and just put in a balloon. So I told him, that doesn't look bad to me. I think you cannot have angina from this lesion and go home. So he went home, but he kept calling me about once a week. He said, I still have these symptoms. I mean, why don't you do anything? So I called him back in a couple of months later. He came back, still the same lesion. And I still was hesitant to put the balloon back into there, so I did the only time in my entire career I did an FFR measurement. And it was normal. I mean, he had angina, typical angina, it was normal. So the only time I used it didn't even work, but it usually works, I have to admit. It does give you the hemodynamic significance usually. But then I told him, well, even in year 2000, we knew that no normal FFR means no angina. So I told him, we don't need to do anything. You have a normal FFR. But then he got kind of upset. He said, well, I'm back now the second time. I have symptoms and you don't do anything. I mean, Grünzig was much more, 20 years ago, he just looked at it, he cured my problem, and what is the problem with you? So finally I caved in, and I did put the balloon in, and it looked good to me, but he looked up at the screen and said, I want the stent. I would have stopped at this point, but he said, I want the stent, but it was before drug-eluting stent, so I had to put in a stent, and admittedly it looked a little better. You know, there's a stent-like picture. Before it was a balloon picture. But of course, a bare metal stent, and I was not surprised that, you know, after a couple of months he called me again, and he said, it was good for about 2 or 3 months, but now I have more symptoms than I ever had in my entire life. I mean, what have you done? And of course, I called him back in, and he had an in-stent restenosis, which then, of course, I did just a balloon angioplasty, and it looked pretty good after that. So then there was quiet for another 14 years. Again, he had stopped all medications because he didn't believe that taking medication and so forth. And then after 14 years, he again called me and said, now I have the symptoms again, so we'll have to have another round together. And I had him back in, and this is what he looked like. And you know, now he had this bare metal stent in there, with which was post-dilated, which had kind of an in-stent restenosis. The initial lesion had been here, so not exactly at the same place, but in the same area. So of course that was in 2014. So he got a drug-eluting stent, and this was the result. And his left ventricle still absolutely normal, and now for the first time also his right coronary artery had some milder lesion, so he also got a drug-eluting stent in his right coronary artery. And now it's been, that was in 2014, another 10 years, and he's fine, you know. He told me this time he didn't stop his medication, but I doubt, because he's now at an age where he probably doesn't remember taking the pills. He's probably willing to take them, but he just forgets taking them. So this is his story. Now the story of PCI, or PTCI as it was called initially, is this one. As we heard before, you know, it's kind of a lot of headwind against doing PCI in the beginning, because people were skeptical. He also said that in India it's the same thing. There was a very slow increase, but finally it took off. And then about 10 years later, the Americans came up with what they called replacement of the balloon. They said, we have better things than the balloon. The balloon was yesterday, now we do atherectomy laser. In Europe, at the same time, we introduced the stents. I mean, actually, Puel in France introduced the stent. But the results of the stented patients looked much worse than the results of the atherectomy patient. Why was that? Stent was only used, as you said, you know, for bailout. When anything went wrong, you put in a stent. And when you looked at those patients, they all had a CK elevation, because the artery was already down when you started bailing them out. Whereas the atherectomy laser cases were elective cases in selected patients. Their results looked okay. But it became quite clear quite rapidly. The only thing that really added something to the balloon was the stent, and not the atherectomy laser. We're not going to replace it. So they kind of went out of the field again. And so finally, people fell in love with the nice view of a stent, and the default stenting became the rule. And then there was, as you know, the problem of in-stent restenosis, which was somewhat more difficult to treat even than restenosis after balloon. And somebody came up with the idea of irradiating the lesion to reduce proliferation, but brachytherapy was really actually a stillbirth, because you had to irradiate 10 people to prevent one restenosis. And this one restenosis you could redilate in 10 minutes or half an hour, but so the complicated procedure of irradiation in 10 people to prevent one redilatation was not a bargain. And of course, at the same time, the drug-eluting stents also appeared, and they reduced restenosis to such an extent that brachytherapy was out of the field. Now, absorbable stents, and here I do disagree with David, were there from the beginning, because everybody knew the stents is really required for hours, days, maybe weeks after at the most, and then the stent is no longer required, should go away. And it has been tried, to do absorbable stents from the beginning. It never worked, and there was a little peak here with the absorbed stent, but also even the absorbed stent, of course, didn't succeed to be competitive with in the meantime, very, very good new, second, third generation drug-eluting stents. And I really don't think that absorbable stents will come back, because it's so hard to compete with the excellence of the drug-eluting stents that we have nowadays. It will be hard to be a match, let alone to be superior to those. And having a stent in there doesn't help you, after a few weeks, but it doesn't really bother you either. Now there's another thing, it's the radial approach. Now the world is radial. Why is that? By the way, the initial corneangiograms were done through the arm, as you know, by zones, and then when Judkins came up with femoral, everybody thought that was much, much better, and everybody moved to femoral, but everybody has moved back to radial. Why is that? In the late 80s, early 90s, the French and the Dutch kind of started doing everything through the radial artery. And they said that's much better, but nobody listened. And Kimeney, one of the protagonists of the radial here, see him, sent me this picture in 1991 or 92, said, why don't you do radial? You like simple approaches, that's what you should do. He said, I do it on the marketplace in Amsterdam. You see, that's Kimeney here, and he said, this guy just had his angiogram, and these people are waiting. He later then told me, this is how he looks today, that actually this were his cath lab team that he put up, just for the picture. But this guy here didn't know what was going on. He just saw that apparently he got something for free at this stall, so he just kind of queued up. Now, of course, then I tried it, but I found out that for doing a radial approach, you needed all this paraphernalia. And actually, a little later, even the ESC recommended you would do it you have to do the puncture with ultrasound, whereas doing my femoral stuff, all I needed was this needle. So I didn't quite see why I would turn to a more complicated way. It was for me like, having had so far a bicycle to use, and all of a sudden now somebody tells me we should do a monocycle. Of course, you can bring out pizza on a monocycle, but you have to learn to do it. It's much easier to bring them out, on a bicycle, and particularly if the terrain gets a little bit more difficult, it's much, much better to have a bicycle than to have a monocycle. But as you know, now the whole world is riding the monocycle. I still have my doubts, but I'll show you why that is. Now, of course, when you learn to ride a monocycle, you have a longer, flatter learning curve, you have crashes and falls, but you're the one that suffers the crashes and falls. But when you do the radial approach, it's not you who suffers because of the long learning curve and the flat learning curve. It's actually the patient who pays the bill, So it's really not quite correct. In addition, you lose maybe not 1 out of 30, but 1 out of 50 radial arteries for no good reason, And if you told the patient then before that, probably not everybody would want it to be radial. But of course, radial has a lot. Let me see. That's kind of okay. It's kind of distorted here. I don't know why. When I tried it out, it looked okay. But okay, but I can still explain it to you. It's a bit hard to explain though, but I think Somehow this thing got... Okay, I don't know why, but anyhow, why do we do radial? The slide is completely distorted.
Okay, so let me just exit and...
Yeah, sure. Yeah, because if all the slides will be distorted from now on, that will not be easy. But anyhow, you know, it was the matrix trial that... here. Yeah, that's the way it should look. Let's see if it's... Okay, now it's perfect. Okay, thank you, bailed me out. Okay, so the matrix trial made the difference, you know, but look at this trial. What it really told us was there is a significant advantage in acute myocardial infarction. That's really where you don't need a radial. Radial is comfortable. The patient can go to the toilet. You don't have to kind of watch the pressure, the femoral puncture site and so forth. It has comfort advantages, but not in acute myocardial infarction patients. They're not going to the toilet an hour after the procedure. They're in the bed anyhow, so you could at least do it femoral. But they showed that there were significantly fewer problems doing it radial than femoral. And that turned the world into the femoral. But look at how these data came about, and you will not believe it. You know, it was those protagonists of the radial, they were desperate to finally have everybody converted to radial. So they organized the matrix trial, and this is their sub-results. If you only look at the high radial users, those who had been radial for 10 years or more, they had a significant difference in favor of doing radial. Those who had actually just participated in the trial but were actually more femoral users than radial users had no difference. If anything, numerically, femoral was better. And those who did about 50-50 already, they had a 50-50. So there was only this kind of fabricated difference in the radial advocates. And the same trial was done by the Safari study with the same amount of people, the same kind of patients. And you can see that there was absolutely no difference, no advantage of radial. But also it's quite obvious there were much fewer complications in this trial. So what they had done, they had blown up, you know, the problems to get a significant difference in the matrix trial. And they managed with this somewhat strange technique to turn over the entire world. That's quite remarkable. And this is how, you know, medical science and science in general is done. You know, you have to consider the conversion factors when you read those papers. You know, here you have a paper, somebody advocates the new thing with an 80% success rate. They say the old thing that I compare it to only at 70%. You should do the new thing, you know, it's clearly better. But these data are adapted. The ones of the new thing are adapted, but also the ones of the old thing are adapted. You know, the new thing is made better than it is. It's shown in a improved kind of, you know, corrected data set. So actually it does only have 70%, but you just made it look better. But not only that, but the old thing is made looking worse than it is. It actually had an 80% success rate. So actually it's the other way around than it is published. So you have to do these corrections when you read medical publications. Now the other thing is FFR. Yeah, and Nick is interested. The FFR, you know, the FAME trial, again, you know, they were advocates of FFR for 20 years, but no heads turned until they came up with the FAME trial. And then everybody kind of got convinced, but the trial is absolutely worthless, and I'll show you why. Because, you know, what they said, and that's true, you know, they said that the events are highest when you have a pathological FFR lower than 0.8. I agree with that. They say if you have a higher FFR, you have very few events. So they say you have to treat those. I agree completely with that. But why not also treating those? Because they also have events. Why wouldn't you want to also prevent those events, although they are admittedly fewer per year than in the ones with a pathological FFR? And this is exactly what they actually showed. You know, in the FAME2 trial, they showed that if you randomize people with a pathological FFR lower than 0.8 to either medical therapy or to PCI. PCI is doing better. I fully agree with that. Of course, you solve the problem. Of course, they do better. And then they say that, you see, they do so well that they actually do as good as the registry patients with the normal FFR. But I say, why not also treat those? Because they also have room for improvement. I mean, you cheat them out of their easy option of also have some improvement. And actually that was proved, in a quite drastic way by the future trial. I call this the fallacy of FFR. First of all, you can see that should have been 1,700 patients randomized to either FFR-guided or angiography-guided PCI. And then the DSMB stopped the trial after 900 patients because there was a mortality disadvantage of having FFR-guided. A mortality disadvantage, they had 17 deaths in the FFR-guided group compared to 7 patients. The DSMB said, you have to stop the trial. That's too dangerous. Do not guide your PCI by FFR, you kill your patients. And you can also see that also there were some initial problems with FFR already. It's not quite innocuous. You do put another wire and stuff, not so good wire, so you had initial problems, and then within the next 12 months you lost patients, significantly more patients than if you just did angiography. This should have been the final nail in the coffin of FFR in clinical medicine. And they had a very hard time to publish that, Rioful told me, because the FFR mafia would review the paper and of course they would not let it pass. And then, of course, is the FLOWER trial, showing exactly the same thing. This trial, they did an acute myocardial infarction, you did the culprit lesion, then you did FFR on the other lesions you saw and only dilated the ones that had a pathological FFR and left the ones that had a normal greater than 0.8, you left alone. Again, that was not a good thing. I mean, it was not significant, but clearly the FFR-guided PCI did worse than the angiography-guided PCI. And why was that? Because, of course, you left lesions behind that should not have been left behind. Although their FFR was normal, they did twice as many myocardial infarctions occurred, additional ones during the next year. So that's very understandable. And then, of course, we know that the FFR mafia continued doing FAME 3, and then they crashed on their face, with a FAME 3 again because of FFR. If they hadn't done it with FFR, they wouldn't have crashed. What did they do? They did multi-lesion patients randomized between surgery and FFR-guided PCI, and surgery significantly did better. If they had just dilated the lesions, but not only the ones with FFR, but all the lesions, if you now put the FLOWER data, just project the FLOWER data on this trial, you can see it would have been a match. So you would have surgery against multi-vessel PCI, but without FFR would be the same results with a much easier intervention. And this is all understandable because, in this huge registry, 32,000 patients, they looked at just 5 years. Was there any difference in death or myocardial infarction, whether they had angina, pathological FFR, or whether they didn't, normal FFR? There was no difference. It's not the FFR that decides the future of having death or myocardial infarction. It is the rupture of a plaque, and of course you have more plaques with a normal FFR than you have with an abnormal FFR, although the individual risk of an abnormal FFR plaque is a bit higher than of a normal FFR plaque, but still, I mean, the accumulated risk is the same, so you should dilate all the plaques that you see that look like they need dilatation, because what we are doing, if we do FFR as a decisive instrument in PCI, we bark up the wrong tree. We bark up the tree of hemodynamically significant lesion. That is what FFR identifies, but that's not where we should be acting. We should prevent plaque rupture. And the cat is sitting on the other tree, so we should not use FFR for our decision making. So to finish the PCI part, the other one part will be short. This is my metaphorical way of how PCI should be used. You know, I call it the curse of life, or the course of life, or if you blank out the O, it's the curse of life. We are, when we are born, we are put on this high plane. And we'd like to stay in the middle of the plane to have the longest possible path, because we're moving on with as years pass by, and I can tell you a story about years passing by myself. Now, coronary heart disease, like any disease, can be shown in this metaphorical picture. You know, initially we're healthy, then at some point in time, like the first patient, you have a first lesion. Now, of course, with drugs, you're stable, you can be stabilized. But you're stable, you're alive, but you're out here. So, of course, PCI can bring you back to the center line. It should bring you back to the center line. And then, of course, with a little luck, everything will be fine. Of course, as we know, the first patient at least had one more, and we may have additional little excursions to the right side. Now, if on the other side here, if at this point in time you have your lesion and you only look at whether you're alive and stable, and this is what all these trials, FAME, COURAGE, ORBITA, ischemia, they only looked at the fact, is the patient stable and alive? Oh yes, okay, then we don't need to do anything, but you're out there. You don't want to be out here, you want to be in the middle. So they completely ignore that you're out here. So the best of all the courses out here is this course. You know, let alone what happens if you have an additional lesion, you'll drop off quite prematurely. So ignore those trials, for heaven's sake. Just do your thing. So PCI, you know, is now close to 50 years old, and I can tell you that the only thing that you really need is the balloon and the stent. And the stent now, of course, is sweating some drugs. That's a very good thing. And all the other things that came and went, you know, you don't need those. I mean, some are nice to have, some are not even nice to have. And the rotablator maybe will solve a very rare case where you cannot push a high-pressure balloon through the lesion. But all the other things you can easily do without. Now, let me just quickly cover the rest. You know, as David also mentioned, you know, I decide between preventive intervention cardiology, which I call mechanical vaccinations. You do something to avoid something that might or might not happen, like being vaccinated against corona or against smallpox. You know, you do it. And this PFO closure is a very easy example of that, and LAA closure is another example. It's not a therapy. You do it to prevent stroke or myocardial infarction because of atrial fibrillation. Cardiac stenting is also actually preventive procedure. And then you have therapeutic procedures, PCI, going from very easy, innocuous to very complicated and dangerous. You have ASD closure, TAVI, and so forth, other therapeutic procedures. Now, I'll have occasion tomorrow to talk about my pet subject, PFO closure, so I'm just submitting to you what we are dealing with, treating now is kind of prevent recurrent ischemic cerebral events in people younger than 60, but that's really just the tip of the iceberg. We should treat all these other indications for PFO closure as well. LAA closure, the other mechanical vaccination of importance, has been shown actually to save lives compared to warfarin. In the Watchman trial at 5 years, there was a significant mortality benefit in people who could take oral anticoagulation if you close the LAA instead with a Watchman. And you can say that's a question of the strategy, because also with a Amplatz device here, an ACP, 1,000 patients just projected on the follow-up. It's the same thing. It's closure against warfarin. You know, you say nowadays we use NOACs, but looking at the randomized Prague 17 trial, you see that mortality benefit is quite likely also to become significant here quite rapidly, because it's not very hard to imagine that bleeding will go on, whereas Here, you know, like a vaccination, you had all your problems during the vaccination and nothing much is happening. So it's going to get significant, and this is now Amulet and Watchman in a mixed group, also against the novel oral anticoagulants. So we should actually submit, and I've been doing that for over 10 years. Every patient with atrial fibrillation gets the recommendation to have the LAA clause before I start anticoagulation, and only if they tell me I don't want this, then I do oral anticoagulation. So the primary technique should be LAA closure. Why is it so good in preventing also ischemic events? That it is good in avoiding bleeding, everybody understands, because you don't use oral anticoagulant. It is good also in preventing ischemic events, or as good as oral anticoagulation, because oral anticoagulation has a bad compliance, whereas LAA closure has 100% compliance. So this is why it's good on both sides. Now, just for the valve at the end, that's also quite of a strange thing, and we've heard excellent talks already by Shafiq and by Daniel about it. You know, 2002, Alain Cribier ingeniously introduced that to interventional cardiology. Very nice thing. And we've heard, you know, that the valve actually is better. You know, the percutaneous valve is not just equally good, it's better. It has a high surface because you don't have this bulky, kind of case that the surgical valve is put in. You have a very narrow stent, a very thin stent, because you have to put it through the femoral artery. So you have a higher surface. Larger surface, and that stays for a long time. So durability, we've heard that is if anything, is even better than surgical valve durability, or at least as good. So why should anybody have surgical aortic valve replacement these days? You know what happened? The surgeons had these shoes, you know. They said, we've been for a long time doing aortic valve replacement. It worked quite well. Well, of course, there are some mountains, like the Mount Everest, we cannot climb up there. Our shoes are not good enough. Why don't you try do that with your new shoe that you say is such a good shoe? Okay, try climbing up Mount Everest, you know, doing it in patients that we cannot do surgery on. We did that many times. We climbed Mount Everest. It worked. Now, of course, we would say if we can climb Mount Everest with these shoes, probably we can also go up this little hill here, you know. But no, you have no data on the hill. You went up Mount Everest, okay, but it's not sure that you can also climb this little hill. You have to do a randomized trial. And we had to wait 10 years, you know, to get finally the proof, which is now a few weeks or a few months out, that we have now the 5-year partner trial showing that, yes, the results are at least as good, if not better, you know, with TAVR than with surgery, that now in most countries, it's being paid to do aortic valve replacement in everybody who needs it, and that should have been done 10 years ago. So many chests were cracked for absolutely no good reason. Now, the battle between surgery or interventional cardiology is quite easy to win. Just ask the patient. You know, ask the patient, what would you want? You know, the day after the procedure, you'll be either like this, you know, if you do it catheter-based, or it'll be like this. I mean, it's a lot of in common. You'll have a dressing here on a scar. You need some attention here of somebody who takes care of you. And, of course, you need some fluid to keep your kind of circulation going. Here also need some fluid. But the patient will probably think it's not quite the same, and he will go for the left side. Thank you.